the passing of a dear friend and longstanding member of the Board of Associates, Major Nathan Klein. Many of you know Nate from his long service in this organization, including a decade spent serving on the executive committee, and also through his robust support of military and veteran causes in our community. We are very grateful to Nate for the time and talent that he shared with us, and he will be greatly missed. Now, given this loss, along with other turnover on our executive committee, we're currently seeking interested candidates from our membership to join the executive committee. The committee meets quarterly on off months of general meetings, and at those meetings we're updated on Lehigh Valley Health Network priorities and strategic direction, and we use that information to plan our upcoming meetings and other board initiatives. If you're interested in considering joining the executive committee, please see or contact our executive secretary, Erin Ludwig, sitting up front. After today's meeting, she'll send you the information and a link to complete an online application. And she will also provide you with an overview of the responsibilities of the executive committee. Now, while today's program concludes our schedule of general programs for this calendar year, I highly encourage you to attend the network's, Lehigh Valley Health Network's community annual meeting, which will be held the evening of December 4th here at Lehigh Valley Hospital Cedar Crest. And again, details of that information are listed on the agenda, and you will also receive a formal invitation to attend. The 2020 schedule of our meetings for next year are also on your agenda. And that schedule will also be printed out in our 2020 membership directory, which will be sent to you shortly after the new year. Now, it is my great privilege and honor to introduce Dr. Tom Whalen, Executive Vice President and Chief Medical Officer for Lehigh Valley Health Network, to give us an update. Welcome.
Thank you, Sybill. From what I'm hearing, Max did his job, and I hope you can all hear me. Max always does his job. Thanks, Max. It's really a privilege to be able to address this wonderful group. As you might suspect, being a chief medical officer, I sometimes am in rooms not filled with friends. And so it's heartwarming to be among friends, and especially to be among some of my former colleagues who are now members of the Board of Associates, so it's always great to reminisce with them as well. I just have a few slides, and as usual, I want to allow plenty of time to try to answer your questions, and you usually are not shy in offering those questions, which is a great thing. Just to kick things off, we are continuing to grow, and without growth, you cannot sustain, and so that's a good thing. And while you might read a lot in the media about growth's positive and negative impacts in terms of healthcare institutions, the reason that I feel wonderful about our growth is born of arrogance. I truly believe that we give extraordinary care that's far better than what is offered in the general community, not offering aspersions upon any network or group of networks. I just think we do a great job, and we have a lot of objective data to demonstrate that we do a great job. And we believe we have largely fulfilled, particularly in this Cedar Crest campus, Leonard Parker Poole's vision to have a superior community hospital. And so you've seen, I think, in recent times that the construction, which is running amok just yards from where you're sitting right now, to double the size of our emergency department is well underway. The winter was not kind, and so we are not exactly where we thought we would be at this particular point in time, but we have been catching up nicely. And once we open that double the capacity emergency department in the new structure, we then retrofit the current emergency department with a doubling of the size of the pediatric emergency room, where the demand continues to grow at incredible rates. And so we're very happy to be doing that, but we acknowledge there's some pain points, and believe me, I hear occasionally from doctors about parking on this campus while we're going through that construction. In Hazleton, any members of the Hazleton community with us today? Well, we're doing a couple of really great things. We're totally redoing their emergency department. We opened the first phase of that quite recently, and now we're redoing the old emergency room again to double the capacity of the emergency department in the Hazleton community. And we're also exploring new advanced ambulatory venues within Luzerne County. We were very excited recently to announce in Lehighton that we will be building a micro-hospital. And there's various definitions of a micro-hospital, but basically it has an emergency department, it has operating rooms, it has inpatient beds. It's just much smaller than anything like this or Muhlenberg or Pocono. And we're very happy to see that despite the fact that the Blue Mountain Health System chose a couple of years ago, somewhat perplexingly from our perspective, to go with St. Luke's over us, although we had been friends for 10 years. Dating couples can break up, I guess. That we remain very market dominant in terms of the preferences of the patients and the people who live in Carbon County. And so there's a yearning for Lehigh Valley Health Network to be in Carbon County, and that facility will fulfill that. Things are now underway, right, on Route 33 and 248 for our new Norco, Northampton County facility. And in Schuylkill County, where we know just 30 days from now that St. Luke's and Geisinger are opening their new hospital at the more southern part of Route 61 towards I-78. We continue to have incredible demand, and we opened an express care there several months ago, and it has just been explosive in terms of going beyond the projections for the number of patients that we thought we would see there, while we sustain the volumes in the emergency department, now consolidated on one campus. So growth is continuing, and there are a couple of more things we'll probably have on a slide for you in your first meeting of 2020 as well, and we look forward to talking to you about that. We're proud of many things that we do, and we're proud of being open-minded and being receptive to all patients, and we're awarded for that stance, as you see on this slide, by the Human Rights Campaign to be one of only 7 top performers in the Commonwealth of Pennsylvania in terms of offering appropriate and sensitive care to the LGBTQ community, and for all that we have invested in terms of policies and practices in terms of being able to do that sort of care. And I know a couple of you mentioned to me, and I'm sure there were several others who just last week or the week before, last week, were at the dedication of the Lutron lobby at the Riley Children's Hospital. Again, just yards from where we're sitting right now. The Children's Hospital is a full-fledged children's hospital here on the Cedar Crest campus, and this beautiful entryway with the colorful lights and the colorful lobby just complements so nicely for the children that will continue to come to see us for their health care needs. And we once again thank both Lutron for what they have done for that lobby and JB and Kathleen Riley for their generosity in terms of the Children's Hospital. A little bit of a progress report on our overall network goals. So we have network goals for all 18,000 of our colleagues who work here and at all of our many sites where we care for the community. And this is patterned upon the triple aim that's become the quadruple aim. So the triple aim was born from a very prominent organization called the IHI, the Institute for Healthcare Improvement, when a gentleman named Don Berwick, a pediatrician, was heading that organization up several years ago. And that was the 3 rightmost on your slide: better health, better care, better cost. We added, as many other organizations in healthcare have added, a 4th part, the quadruple aim, and that's the first one on the left, the better colleague experience. And so it's a highly stressful environment to be in healthcare. We get the opportunity and the privilege to do great things with our patients, but everybody's working pretty hard. And if we don't take care of the chassis of the 18,000 people, all inclusive, from the valet parkers that you may have seen when you first arrived on this campus to the neurosurgeons, and whether or not they're the top of the heap, they think they're the top of the heap, so I'll say the neurosurgeons, and everybody in between, that we know we have to care for those people in order for them to care for others. And so in FY19, we closed the books on a very successful year on 30 June, and we did extremely well with all of our goals. And basically, better colleague experience. Lynn Turner, who I think you have had address you before, who's our Chief Human Resource Officer, is the senior-most colleague who heads up that part of our goals. Better health is mine, and you're going to hear a very critical part of what we're doing in FY20 when you hear from Ed Norris in just a little while, the chairman of the Department of Psychiatry, but we also, with the clinical depression management goal, but also we have done well in terms of managing diabetes, and in the inpatient environment, decreasing hospital readmissions, which we continue to work on in this new fiscal year. Terry Capuano, who I know has addressed you many times, my BFF, is in charge of better care. And so that's basically aimed at making sure patients get a great experience, but also getting them in the door because of the demands that we face for our community. And then better cost, the Chief Financial Officer, Tom Marcosi, is in charge of that one. I don't think you've heard from him, and you haven't missed anything, so don't worry about it. So that's our goals for the most recent year and for this year going forward. And then a plug. So I'm not sure. Anybody here like to listen to podcasts? Anybody? Yeah, there's a few, a smattering. I've become engrossed in podcasts. And a couple of my favorites, I'll give you a tip, one is Hidden Brain from National NPR, National Public Radio. It's about social psychology and the underneath the surface motivations for what we do. But there's one almost as great as Hidden Brain, which has just recently been released, and it's mine. So it's coming with the theme that we have in our marketing efforts of being your partner, and you've seen a lot of that, I hope, in these last several months. The podcast is called Essential Partners, and there's only 2 episodes presently available if you wanted to stream them, and you can, if you have an iPhone, you already have a podcast app, Apple Podcasts, on your iPhone. You can find it in any of the others, both Android and Apple podcast applications. You just search for Essential Partners and you'll find it. And the first one that I did was Dr. Deb Brandon, who's the Vice Chair of the Department of Family Medicine and the President-elect of our medical staff, on what family medicine is all about today and how critical that primary care is for all of us as individuals and for the greater community. And the second one is Dr. Matt McCambridge, our Chief Patient and Patient Safety and Quality Officer. Matt's an intensivist who heads up those efforts, and he gives a very transparent accounting of his own encounter with burnout, which affects 50% of all physicians right now, and how he was able, fortunately, to overcome that burnout with a great family structure and social structure that he had. But it's a very heartwarming story. And the interviewer's okay, but that's not the important part. It's Deb and Matt. So I highly encourage you to try to take a listen to those. So, with that out of the way, the more important part of having the opportunity and the privilege of being here with you is to answer any and all questions that I can, unless it's a question protected by CIA privacy rights. Sir.
According to the media, the latest acquisition of the health network, coordinated health network, which had an outstanding debt of $400 million, which brings our total debt to $1 billion. And according to our own financial experts, it's above the ideal level. Could that lead to a lowering of a credit rating, which will increase your borrowing cost in the future?
So I'd be delighted to find your source, because $400 million is absolutely erroneous. Yeah, well, it wouldn't be the first time the morning call got something wrong, with any due respect to anybody in the morning call or maybe in the audience. 400 million is a tenfold exaggeration. It's approximately 40 million. That debt is incorporated into the structure of the deal, so that we actually, if allowed by the Federal Trade Commission and the Pennsylvania Attorney General Office, which is still a very big question, and we're under that process right now of being under the microscope for what this means for market share and whether the regulatory agencies will allow it to go forward. But if it were to go forward, if you had tried to acquire Coordinated Health 2 years ago before their financial problems erupted, and it really has been that sudden, we would have paid significantly more than the combined price of what the acquisition will be and coverage of the debt to acquire that business, which still, we believe, is a profitable business. There's a number of intricacies to the due diligence that has been completed in how they worked between Coordinated Health, the caregiving entity, and Coordinated Health Real Estate, both owned by the one physician, that really led to the growth of one at the expense of the other, which would not be sustained in the new world.
Exceeding $1 billion total debt, which is above, according to our own financial.
Right. So he's asking about exceeding the $1 billion debt. With all due respect, that's patterned upon a $400 million figure that's totally erroneous. And so we're not going anywhere near that level of debt because it's not $400 million to acquire the entity. So once again, the morning call has not portrayed things realistically. Karen?
Dr. Whalen, is your podcast available on the website for Lehigh Valley Hospital?
It's not available on the public-facing website. It's only available on the intranet for employees.
Could
right?
you get it on the website?
I can ask.
Yeah. Yeah, as I understand it, and that's actually where it's, unfortunately, it's most often listened on the internet, which means people are listening to it at work, which wasn't exactly the idea. But, you know, it's all good.
Second question. When you drive into Lehigh Valley Hospital
Here. Okay.
And with the magnitude of the growth with Lehigh Valley Hospital and St. Luke's, doesn't this warrant a medical school in this area?
Well,
We were larger than Scranton.
yeah. So, you know, to have a full-fledged 4-year independent medical school requires that you have the first 2 years of medical school education. As you know, your son went through it. And that's all the basic sciences. So you need a plethora of basic scientists. And in academia, because I came from there, as many of us did, those basic scientists are challenging in that most of them, and I don't blame them, wish to pursue academic pursuit and research. And they regard that as their mission. And that's great. We need that. But it's really about teaching students what a medical school should be focused on and producing physicians for the next generation. So that's why we chose, as did Luke's, to partner with a medical school to provide the clinical education, years 3 and 4, building upon our strength of delivering exceptional care and molding the students during those clinical years of 3 and 4 into what we feel should be the caregivers of the future after they had already formulated their basic science foundation at the University of South Florida in Tampa. So we would generate further debt if we were to build a 4-year medical school. And honestly, for many of us, Dr. Nestor and I among them, we kind of escaped the sometimes nefarious politics of the 4-year medical school with all the basic scientists to come to somewhere where we can care for people and teach the future physicians in both undergraduate medical education and graduate medical education.
Okay, thank you.
Good afternoon.
Hi.
I have a question with the ER doubling in size. You're not expanding, of course, the rooms in the hospital. So how are you going to handle the incoming people? Because over the last couple of years, I've had family members in and out of the ER, excellent care, but they waited in the ER for like 11 to 12 hours till they got into a room. So I was wondering how you're going to handle that.
So a great question. We, like the entirety of the Commonwealth of Pennsylvania, are seriously still over-bedded in terms of the necessity for beds in the entire state. And the future of healthcare is that things, and we can argue about this, but the horse has left the barn. Things like when I was a young resident, which was when Alexander Fleming was inventing penicillin, basically 2 eons ago. For an inguinal hernia, we would admit you the day before. We would do the operation the next day, and you would stay overnight, and you'd go home the following day. So you basically have a 48-hour admission. And now, of course, if you have an inguinal hernia, you come in, you lie on a table, and a half an hour later you're gone. And it's done under local regional. That's just one example of the trend of healthcare. Unless you're a horribly overwhelming trauma patient with head injuries and long bone fractures and God knows what else, or even something like a Whipple procedure for pancreatic cancer, even a Whipple procedure, you're supposed to stay no more than 3.5 days. So the contraction of that inpatient volume with the elevation in severity has made the number of beds less critical than the intensity of the care that's delivered at that shrinking number of beds. And so we had done a projection, Ed Doherty did this, who may have addressed you in the past. This was 7 or 8 years ago when Ron Swinford was still our CEO. How many beds would we need if we were to sustain conditions as they were? And we would have had to increase them significantly. We would have had to build like 2 additional Muhlenbergs to accommodate it. But we knew that the trend in healthcare and what the payers were dictating to us in terms of what they would reimburse us for, including the government, our biggest payer, was such that we had to re-engineer the care. And so that's the answer, is we have to make sure that we're delivering everything in the ambulatory environment that can possibly be done in the ambulatory environment.
So with the robotic surgery and the advancements in surgeries, you're here in less time.
Right.
So that should create enough beds available if enough people in the emergency room need to use them.
Right. And
hopefully you can treat some of the people in the emergency room and send them on their way.
Send them on their way, and also part of that emergency room is an observation unit.
Oh, okay.
So we currently have observation units in the pool building in our current chassis that will be available now for private rooms in the pool building, and try to get rid of some of those semi-private rooms, but also accommodate the shorter stay patients in the ED.
Hello. Hi, Dr. Whelan. I have a question about the new Riley Hospital, Children's Hospital. I was at the dedication, beautiful. But why is there not a direct entrance into the Children's Hospital?
Well,
I have had. Well,
so that entrance is the one that is facing west, right? So perpendicular coming out to where we are right now. That is the Children's Hospital entrance. I think what you're asking is, could you go in and be right on the children's ward rather than going up an elevator?
Yes.
Well, that would have required a new building, and then we would have been adding more debt, a couple of $100 million more.
Yes, I understand. I figured that was the case, but working in the auxiliary shop a lot, as you know, questions have arisen, and they said, well, they're not directing the people any differently than they had before. Because
well, actually, there is going to be signage, and there is going to be, and I don't know what the state of it is just yet, but there is going to be, not yellow brick roads, but pathways created where, indeed, it'll be much more apparent to where you need to go. I get where you're coming from. It's a big, confusing place. I often say I'm the most highly overpaid tour guide when I walk these halls, because you always see people with a piece of paper going around, like this, and they don't know where the heck they are, and I understand that. Yeah. So we're going to try to make it as clear as we can. You're right. It would have been perfect. I remember when Elliott was still CEO, we had drawings of a 7-story structure in front of, taking down the 1210 building and kind of going out to where that parking structure is, the It's been here now for 13 years, but and it was a beautiful, separate children's hospital. But again, I go to my bookkeeper. We don't want to do that. That would have cost far too much.
Okay, all right. Thank you.
Thank you.
Thank you very much, Dr. Riley. And now it's my pleasure to introduce our featured speaker, Dr. Edward Norris. He's the chair of the Department of Psychiatry here at Lehigh Valley Health Network and professor of psychiatry at the University of South Florida College of Medicine, which is our academic partner. So welcome, Dr. Norris.
Thank you. Thank you very much. And also on sound, it sounds like this is working well. Good afternoon. So it's my privilege to get to give you all an update on the Department of Psychiatry here at LVHN, which includes the Greater Lehigh Valley and also Pocono and Schuylkill. And in my experience, rather than get to the good things that we're doing, I'm going to start with the rumor that everyone already knows. There's not enough mental health care in the Valley. There's not enough mental health care in the United States. And people don't take my word for it, so here's some data and published studies, but essentially downtown Allentown is considered an area with significant mental health professional shortages, where you're supposed to have roughly 26 psychiatrists per 100,000. They have about 1 per 30,000, or 3. So, you know, a shortage of 23 psychiatrists per 100,000 in this area. How does that affect us? It affects us with the ability to recruit people. It affects other people to bring in psychiatrists, and it's a known problem. The other challenge that I face and LVHN faces is half the psychiatrists in the country do not take insurance. They don't deal with LVHN, they don't deal with insurance, they don't deal with Medicare. I can tell you their model, but essentially they're private practice. You buy a seat, you go see them. Whether you have insurance or not, you pay their full price. That is not what LVHN and my department is trying to solve. We're trying to get care for the people of the community who really need it. So now I'm going to get to talk about all the fun things that we're doing and the great things that we're doing in the department. So first of all, when you look at the Department of Psychiatry, we're fairly large, and we're by far the largest provider of the Lehigh Valley. We start with emergency services. So just in the Lehigh Valley, every single emergency room has psychiatric emergency services. So in crisis, all of our emergency services can be handled, and that includes the same for Pocono, Schuylkill, and Hazleton. Here we then go to our inpatient unit, and at Muhlenberg is our main inpatient site in the Lehigh Valley, and we have 65 beds. We actually also have 20 beds at Pocono and another 60 beds at Lehigh Valley Schuylkill. And that's where services end up north, acute 24-hour psychiatric services. But what we have here, what I really say right now at this time, south of 22, is the rest of our continuum. So from inpatient psychiatry, everyone knows that people walk to an inpatient psychiatry room, we watch them 24/7. The rest of the hospital beds are served by the consult liaison service. So all the beds on this campus, all the medical beds at Muhlenberg, actually all the medical beds at Schuylkill, this team actually beams up to Schuylkill and does those consults. We're working with Hazleton to do that as well. So those are services provided to other medical patients in our hospitals. Then our next continuum is lower acuity, what we refer to as our partial hospitals. And patients in partial hospitals go basically Monday through Friday from about 8 in the morning to 3 in the afternoon. So it's an intensive group-based treatment, and then they go home at night because they've already been deemed safe to go home and come back the next morning, but it's more intense services. From there, they step down to our outpatient services, and we really have two practice types. One is more of a physician-type practice. So this is where we see patients who have commercial insurances. And then we have two mental health clinics where we really see people who have Medicaid and no insurance, and actually concentrate our services differently because we're able to care for patients in a different way. And this is replicated throughout the country with both mental health clinics and professional practices. We actually have residential programs. So at the Riverbend Apartments, we actually have 38 beds. And the average length of stay for our residents there is 9 to 12 months. And people here go and they get all the help to get the skills to manage their medicines independently, learn how to shop again, learn how to cook, learn how to apply for and hold a job, and then we help them transition back into the community where they can live independently. Finally, we have administrative offices that help oversee all of this. And then in our next stretch to reach more patients, we have behavioral health integration. And that is where, rather than coming to see psychiatry, you go to your primary care practice and you're able to see a counselor in that primary care practice. And this number always changes. Right now it's 36 behavioral health specialists, which are licensed clinical social workers or licensed professional counselors. It was in 72 locations. We're now up to 95 locations, but it's an ever-changing number. And then 5 years ago, we went to SAMHSA, a national foundation, and we said, we think psychiatric patients will get better care if we actually embed family medicine into one of our practices. And we did exactly that. So under a 4-year grant, we embedded a family medicine practice provider within our mental health clinic, and patients were able to get both their mental health care and their medical care under one site. And actually what we showed is that, believe it or not, patient health outcomes improved, their numbers got better. They actually felt more connected to their care, and then they used the hospital less, and they used the emergency department less. It's what you would want to see. Finally, we have education, and we're involved with PCOM PA students and nurse practitioner students. Of course, the University of South Florida College of Medicine with psychiatry students, and now our own residency program, which we developed and recently launched this last year. So that's the breadth of our services. So when you look at the number of patients that we treated, in the emergency room, we saw nearly 6,000 patients. On the inpatient unit, we admitted 2,300 patients and nearly 20,000 patient days. In the partial hospital, we cared for another 1,500 patients. Our CL service saw nearly 5,000 patients throughout the medical floors. We had 9,400 patients under care, and we saw those patients 63,000 times. And our residential, we actually had 51 residents for 12,000 days. So in total, last year, we cared for over 23,000 patients and over 124,000 patient days or visits. Both of those numbers were an all-time high. But as we know, it's not enough. And so here is how we're addressing how we're going to try to move forward and better help our community. So these are the 25 employed and 18 employed advanced practice clinicians in the department. And you can see that they stretch from inpatient and outpatient. But we have some contracted people as well. But what's noticeable is this part. The people in red, those are 12 new providers that we have been able to recruit and have come here in the last year. So the department, through the support of Tom Whalen and the network, is actively recruiting more providers so that we can have more access. So this is the magnitude of our access issue, right? Last year I had over 18,000 requests for outpatient care. We did miraculous things, and we got more patients in than we ever had, and we got in over 2,300 new patients. But if you flip that around, 1 in 9 patients is getting in, and 8 out of 9 are not being able to get into services just due to the magnitude of demand. And so, unfortunately, this is a problem that we face, and there's a lot of ways that we're going to go about trying to address it. And the fact that we're tracking it and looking at it and everybody knows about it allows all of our primary care practitioners to partner with psychiatry to think about new models of care. So The first thing that we're doing is a lot of work with telepsychiatry, and we've actually been involved with telepsychiatry for over 10 years. And the first three are standard type care. So if you come into the emergency room in the middle of the night, we have somebody who is always on. They may beam in and see that patient. So that's telepsychiatry. So we can get our services in our emergency rooms whenever we need to. 5 years ago, we worked with the courts. So some patients are voluntary and sign themselves into our units, and other patients are involuntary, where we have the ability with physicians and community to put them in involuntarily, but after 5 days, the court adjudicates on whether or not they get to stay longer or they're discharged. And so our courts actually beam in and have those hearings through telecourt. We are now an Epic shop. As you probably heard, we went live with Epic Leap yesterday to all of our inpatient hospitals, and so we've already done that with our outpatient hospitals. And so anybody within the network on Epic can say, I would like psychiatric help with their patient, and they can put in an e-consult that comes to my psychiatrist, who review the chart and get back to that doctor. That's just another way we're trying to push out what we can do and partner with our other primary care providers. The last four we've actually turned on in the last 6 months. So we now have the ability to beam into a primary care office and interview and evaluate a patient who a primary care doctor wants a second opinion or further help, and give that doctor real-time feedback. Now, we're in a pilot program, and so there's 2 programs that we're doing that with right now, and we're troubleshooting the process to try to make that as more effective as possible. We've turned on consults to the medical floors in Schuylkill. In the last 6 months, between January and June, we did over 200 consults to Schuylkill to help out our colleagues up there. We now do telehomeless, and so telehomeless actually is telehomeless to the food kitchen, because the food kitchen has the proper bandwidth and other things to support video. And patients who are homeless, one of the first steps that they need to even access care is to get a mental health evaluation so that they can start their Medicaid application process. So we've turned that on to try to help our community. And then finally, under an agreement that we have with our own health care plan, Populytics, because none of these tele-initiatives are supported through insurance or through payment. These are all just innovative types of care. We now beam into patients' homes who we've seen and either are challenged significantly with anxiety or mobility, and can give them therapy over our LVHN, my LVHN app. And so rather than coming into our office, we can meet them where they are. Those are some of the things that we're doing to expand our access. Some of the most exciting things that we've done also is we started from scratch and we applied for a residency program, and we were accepted. And last year we sorted our first group of applicants, and we actually had nearly 900 applicants for our 4 spots. And we interviewed 60 of those, and we matched, and at the end of the day, we matched 4 wonderful residents. And so one came from Penn State, one came from our own USF College of Medicine, one came from Geisinger School of Medicine, and one from PCOM. In the world of matches and first-year programs, you tend not to have the success. I think it just speaks to the recognition of LVHN and the type of education that can be provided here. When we look at other aspects of education, we're looking to push education to our community. We have a behavioral health education specialist who is funded through an endowment, and the purpose of this person is to push out education to our patients, to our community, to our providers, and to anyone of the Lehigh Valley around mental health wellness, mental health treatment. We've started our psychiatry residency program to expand the number of psychiatrists who we hope to recruit. It's an open secret that I want to train these young doctors, and then I want to recruit them to stay here in the network in the area. We will develop a child and adolescent fellowship so that we can provide more care for our children in the area. Some of the offshoots of actually developing a residency program is the fact that a company out of California provides nonprofit grants and is in the process of working with us to provide us a research scholar to help our residents and our faculty with their education and their research publications, which is part of the requirements of having a program. We do education within our network. We train our own critical incident stress management team, which is a partnership with employee resources as well as emergency management so that we can deploy a team in the setting of crises and help debrief. We've trained over 1,300 employees on Code Orange training, which is how we deal with agitated patients in any setting of the hospital. And then Dr. Whalen mentioned it earlier, but we're rolling out a depression pathway to all of primary care. And one of the network goals this year is that patients are screened and then given appropriate follow-up throughout the entire primary care continuum. And so our goal is to support primary care with all of the patients who need our help. And then finally, as one of the first departments to actually be able to develop an app, we have an app that is available to the public. And so even my wife says nobody uses apps anymore. But rather than Google and go wherever Google can take you, we have an app that doesn't contain PHI or our own personal health information, but it has vetted sources that the Department of Psychiatry and the Division of Education say these are appropriate sources and appropriate reading levels for people to understand what's available for themselves and in the community. And so now here's the leap of faith that we were joking earlier. With technology and an app, we're going to have to use an old-fashioned presentation tool. And here we are. So in the world, there's a platform called Guidebook, and Guidebook is actually used by a lot of colleges to aggregate a whole bunch of data. If we were doing a 3-day seminar, we could use that to control all that data. We worked with them and repurposed it to hold information that's important for patients. So the first thing is, if you want to find out more about your psychiatrist that you're seeing, in fact, this links right through to LVHN Find a Doctor, and hopefully I've not set off my... or to the mental health clinic, which I disabled my tracking for this presentation, which will actually give you directions on how to get there. More importantly, if you're on an antidepressant, let's say Lexapro, and you're not sure of what... So the last time I did this live, and my son said, "You are the bravest person in the world to actually allow anybody to potentially text you during your presentation." So, of course, I did it the opposite way this time. Okay. Yeah. So, going back to where I was, sorry about that, medicine and antidepressant, and let's say I'm on Lexapro, it links us right through to Medline Plus, so it's always up to date. And what do I do if I've forgotten forget to take a dose, and all the information is right there. So rather than trying to search for your pamphlet or other things that I handed to you when I saw you, this is with you, and it's on your phone or your app. Finally, the aspect of things that we're most really excited about are there's a number of self-help tools here. So how to do breathing exercises. Well, I'm waiting in the waiting room and I forgot my piece of paper. It's on my app. I can just go right to here and practice along with that app. There are links to education. There are links to video. Ultimately, what we're trying to do is make the information that's important for our patients and our community easier to access. And then finally, with emergency resources, it links to all of the areas, crisis intervention lines or text lines, and so patients have access to emergency resources as well if they were to need it. And so that's just one of the tools that we've been trying to use to improve care to the community. Interestingly, the next step with this is clearly how do you have two-way communication. And two-way communication within apps is a much more complicated step because it involves patient information, but we're working with information services to eventually get that to fruition as well. So with that overview, I am happy to answer any questions that you might have.
Hi, thank you for this. It was interesting to see your call out of the new folks, your new partners, and among them there were several CRNPs and PAs. Mm-hmm. So you can help me understand. My sense is that the pressing needs in primary care was addressed. Those needs were addressed through the infusion of more PAs and I keep getting those CNRPs, script writing, and on the front lines helping the primary care physicians, and because of that, it's addressed that urgent need to a certain degree. And my impression has been that in mental health, seems to have been some resistance to that kind of support coming in from certified registered nurse practitioners and PAs. Is that just a falsehood, or am I onto something? Is there less resistance nowadays?
Let me ask a clarifying question before you give the microphone away. Are you talking about a resistance of patients or a resistance of providers?
Resistance of providers in the profession of perhaps including and expanding those health providers who can write scripts in the field of mental.
Right, and so there is definitely a divide in the world of physicians, right? Because many physicians see advanced practice clinicians, which both PAs and CRNPs fall under, as encroaching upon their territory. Taking a step back to the very beginning of my presentation, half the psychiatrists in the world just don't deal with insurance or anything. So it depends on what you're trying to solve for. We're trying to solve for access. And so our model here, which is how do we do more for more people with the resources that we have. So as we have CRNPs that want to join us and work with us, they actually partner with us. The training for a CRNP is very different than a physician and a psychiatrist, but we bring them on and we actually train them after they've graduated to work with us both on the inpatient units where they see every patient with us, and then ultimately to the outpatient arena where they are able to see patients independently with a physician oversight. And so that is our model. That's another way to expand patient care. The other concern, the other problem is there's such a shortage of providers. All of our schedules are full. So if somebody has a problem and an urgent condition that needs to be seen, how do we even get them in to be seen that doesn't either cascade to all the other patients who are waiting to be seen? And one of the ways we also do handle that situation is with CRNPs who are able to see crises and create a pop-off valve for emergencies.
Dr. Norris, you indicated that you have telemedicine in food clinics, food pantries. You can't have them in all. Is this with the in the food kitchens? But they can't be in all of the food kitchens.
Correct.
Is this with the Lehigh Valley Council of Churches, or?
So we pair with the homeless team, and so the homeless team reaches out to a number of street medicine reaches out to a number of homeless people, and so we partner with street medicine. So street medicine works with us to say, we believe that Ed Norris is going to be here today and we would like him seen, so we actually have bilingual therapists on the back end to see Ed Norris if he actually makes it to the food kitchen for the lunch that they often provide.
I was wondering what food kitchen?
I don't know the answer to that. It's where street medicine works, and my understanding is it's different locations every day. Yeah.
My question is, if someone has MS or a heart condition or cancer or whatever, the family can speak openly about that condition. Why is there such a mystery about someone in the family having a mental condition?
Sure. There's a lot of stigma about mental illness. I would argue that in the last 20 years, there's been a significant decrease in that amount of stigma, in the fact that so many people now step out and talk about their mental illness. And notably, really, celebrities are the ones who are forefront in trying to get people to accept it more, often through tragedies, such as Robin Williams, but other people talk about their struggles with depression and their success in getting treatment. And so there is still stigma, but the more that people understand that it's actually a brain illness, the more that people step up and look for care. So we actually partner with NAMI and other groups that are really working on trying to decrease the stigma around mental illness.
Marijuana is in the news a lot, including with mental health issues, for anxiety, or it's more potent and causes psychosis. What are your views on that?
So, interestingly enough, the state of Pennsylvania, or Commonwealth of Pennsylvania, allows for certification of marijuana for a number of conditions. If you review my group that has reviewed the literature to look at the use of medical marijuana in these conditions, at this time there's no good data that suggests that it's useful and that it scientifically or statistically separates in a way that's meaningful. In my opinion, much of the medical marijuana use is much more recreational based, and there are some cases that there's pretty good evidence with some juvenile epilepsy and some other cases, but in the world of mental health, the consequences and downstream problems that it causes do not outweigh any of the benefits, and I'm not aware of any good scientific studies that have weighed in on that. And so at this point, we don't endorse medical marijuana for any psychiatric illnesses. The microphone's coming.
One of the things that you addressed was insurance and having a slight knowledge of psychiatric care. When will the psychiatrist, wanting us to accept mental illness as an illness, when will that take over for them accepting insurance?
It's a wonderful question. So I point that out just to let you know that this is the problem that we face. And so that if you take the field, many of the psychiatrists don't live outside of major metropolitan areas, which is not Allentown, which I personally love Allentown, but they live in New York, they live in Boston, they live in Washington, D.C. when this ultimately changes is really more of, we all recognize the importance of caring for the entire person. We know that when you provide mental health care for patients who are medically ill, they have better medical outcomes. They take better care of themselves, but separate from that, there are connections with mental illness, specifically depression and heart attack. So if you had a heart attack and you're depressed at the same time, you're more likely to actually die from your heart attack, irregardless of taking medicines or complying. It's just the physical presence of that illness with that heart attack. So we all recognize, and LVHN is one of the leaders of this area in supporting mental health to as many patients as we can to try to improve that outcome. But at the end of the day, only when insurance companies take care of the whole patient and are responsible for episodes of care and really value does mental health turn to the other side of the equation where it gets equal reimbursement that would drive people towards it. Yes.
Thank you.
Yes.
Thank you very much.
Thank you.
Join me in
Thank you for your
welcoming
question.
Sorry we don't have time for more questions. We need to wrap up here. I just have a couple of real quick closing comments. I want to thank you to our presenters today. And again, Dr. Norris, thank you for educating us on that. You all have, as a handout, network news. I encourage you to take this with you. This does have the schedule of the flu shot, drive-through flu shots, other important information that we ask you to share with your family, friends, and neighbors on how they can benefit from LVHN services. To our guests, if you enjoyed the program today, we encourage you to consider becoming a member of the Board of Associates. There's information out there at the registration desk that you can fill out with your member host. And a reminder to our current members, if you're interested in considering serving on the executive committee, please see Erin, and she will get you the information. This is, as I said, our last official program for the calendar year other than the LVHN annual community meeting. I look forward to seeing you there hopefully in December. If not, we look forward to seeing you at our first program of 2020 in February, and wish you the best for a happy, healthy holiday. Thank you.
I have always encouraged people to all your side of the story.